Hello, and welcome to Scandinavia House tonight. I'm Sally Yurkovich, Director of Educational Exchange and Special Projects at the American Scandinavian Foundation. That long title means basically that I oversee all of our fellowships and grants programs. So tonight, I'm very pleased to be able to introduce you to Tony Sandset, who is a recipient of one of our visiting lectureship this last year. Every year, we support one Norwegian scholar to come to the U.S. for a semester to lecture at a U.S. university. Tony, this year, was at Southern Methodist University, working with the Department of Anthropology and teaching a course entitled Health as a Human Right. In Norway, Tony is a research fellow at the Center for Sustainable Healthcare Education at the University of Oslo. His research focuses upon health equity and sustainability and the right to health. So this year he was teaching the course entitled Health as a Human Right, and also helping the anthropology department build an international scholarly program for its global health program. In the past, he was a visiting scholar at the University of California at Berkeley, and he's keenly interested in fostering long-term collaborations on both sides of the Atlantic. He's made a good start of that now, and we're very pleased to have been able to support him this past semester. Tonight, he's going to talk about how do pandemics end, the impact of pandemics on our ideas about healthcare, and how it is provided. Tony?
Thank you, Sally, for that generous introduction, and thank you to all of you who've made it here today. I'm really grateful that you have taken the time to come here and listen to me talk. So today's title of the talk is How Do Pandemics End? And many of you might have already the pandemic has certainly taken a toll on many of us, so this might be a topic that for some would seem I'm a bit passé, but I think it has some really good and important points that I would like to talk to you about today. I'll keep this presentation or talk, I should say, fairly general. It won't be too topic specific, so I'll go through some main lines about the pandemic and what it can teach us about healthcare, how we prepare for the next pandemic, and what happened during the pandemic on both sides of the Atlantic. As Sally said, I'm very passionate about fostering collaborations between, in my case, Norway and the US, but that also means looking at health across the Atlantic. And obviously the pandemic hit both Norway and the US and obviously the globe differently, yet had some similarities that I want to talk about today. So this is the layout for the talk. I'll keep it pretty brief, but first of all, I want to talk about how pandemics or epidemics end, because it's an important question in terms of how we also prepare for them. Then I'll go through what's called pandemic preparedness and its effect on how we provide healthcare, and then healthcare during the pandemic, as many of you also probably have been privy to in the media or in your own social lives. And then we'll talk a little bit about vaccines, which I've dubbed here the pandemic's greatest success and its greatest failure, ? And I'll try to talk a little bit about that. And finally, the question, will there be another pandemic? I'm sure you can already now guess the answer to that. The idea then becomes, how do we prepare? What do we do under the next one? And what can we learn from what we've all been through in different ways? And I think I have 45 minutes, but I'll try to keep it fairly concise so that we can open up for some questions. So I might as well just jump into it. So how do pandemics end? And the answer is they don't. Pandemics and epidemics rarely end. As Sally said, I am a researcher of predominantly HIV and AIDS prevention. So I worked a lot on HIV but also on other infectious diseases. And from history, we know that pandemics and epidemics, they don't end. They just transform, as I will show you. And which is a bit odd because we live in what could be considered the era of ending diseases. We really live in an era of ending diseases, and the Sustainable Development Goals, which all UN nations have signed, has as its target 3.3 that we're going to end HIV, tuberculosis, malaria, and combat a range of other diseases such as hepatitis and so-called neglected tropical diseases. And there's major optimisms that we'll be able to do all of this globally within 2030. That's quite some optimism, I would say. And it's a laudable goal, but with the realization that we only ever eliminated one infectious disease, smallpox. Is this optimism warranted? And what does it say about our ability to handle pandemics and epidemics? What can we learn from, for instance, COVID in terms of these things? And I think part of this optimism stems from the 1970s across both sides of the Atlantic. In the global north, epidemics were for the longest time seen as a foregone conclusion. In the 70s, there was actually a rather, some would say, infamous statement by now, made by the current Surgeon General here in the US, that said that infectious diseases were now over in the West. The only thing that mattered now was non-communicable diseases, or so-called lifestyle diseases. And while it's true that lifestyle diseases or non-communicable diseases, chronic diseases, are a major burden of health and morbidity in the global north, obviously something was missed. I could mention here, obviously, that this optimism was somewhat tempered during the 1980s when HIV and AIDS epidemic suddenly emerged on the scene, and obviously now with COVID-19. So in a sense, it's strange that we are so geared on and keen on eliminating and eradicating infectious diseases when we have such a poor track record of doing so. And here I'm not saying that it's not laudable, and actually we should obviously try to do it, but I think COVID has shown us some of the gaps that needs to be addressed in order to actually make good on the promise of ending epidemics and pandemics. As I said, obviously, most of the times epidemics just turn into endemics. They become part of our everyday life. Most epidemics never truly end. They just linger in different states. Often they transition from an epidemic state to an endemic state. Some become cyclical, like the common flu. We haven't eradicated that, and it comes back to us every winter here in the global north, where we lie with stuffy noses and fevers. Yet some in turn never leave, but they are there as a slow burn that slowly sap away the vitality of the population. Case in point here would be something that I'm familiar with part of my work with Doctors Without Borders, which I'm also part of, where neglected tropical diseases is a term, but neglected for whom? These epidemics are not neglected by the people who are affected by them, and these diseases are dengue fever, Chagas disease, etc. A lot of what's called tropical diseases. They're obviously not neglected by the people who suffers from them, but they're neglected politically, in the media, and by medical research in terms of finding biomedical cures or vaccines for them. So my point here is just to say that epidemics rarely end. And you probably now think that you've entered into a talk where there will only be dystopic pictures of a bleak future, but I do have some optimistic viewpoints that I would like to present to you, and I'll obviously also discuss with you. Because epidemic endings are also a common endeavor for all of us. You don't have to be medical doctors. Actually, this responsibility lies very much so also within the population, I think, and I'll get back to that. So just coming back to the idea of how epidemics end, they often just seem to end when there's no more political attention to them. One might say, as a colleague of mine said, an epidemic ends when it no longer represents a political problem, or that it no longer makes media headlines. We all remember Zika when that threat came. Zika is still endemic, yet we rarely hear about it. So I think that's my first point that I would like for you to consider, the idea that epidemics end when they are no longer politically relevant. However, there are also other endings to this. Building on a colleague of mine who's a professor at Oxford, Erica Charters, who does wonderful work on epidemic endings, I would say actually that pandemic endings or epidemic endings have social endings, they're political endings, and cultural endings. Or as I write here, social, political, biomedical, and cultural. And let me just go quickly through them just to make sure that I explain what I mean here, because I think this is also important in terms of COVID-19, in terms of how different people perceive COVID to be over. And this also obviously goes for other epidemics as well. For instance, my own work on HIV in Norway, HIV never really became a large-scale epidemic in Norway. It's a very small, concentrated epidemic in Norway. So when I tell people that I do research on HIV in Norway, people say, wait, isn't HIV over? Well, it's predominantly over for the majority of the population, but for the 4,000 people living with HIV, it's still very much there. And the same with COVID. So epidemics have their political, social, biomedical, and economic ends. Biomedical, we could say, is when cases fall below a certain threshold. This is more epidemiological endings, when medical doctors say, oh, cases have dropped, it's no longer an epidemic or pandemic, it's over. Then we have political endings. And that's probably when the pandemic is no longer politically seen as a problem of politics or prioritization. When we remove various pandemic mitigation efforts. Economic, when the pandemic no longer is considered an economic problem or an issue for society's economic wheels to turn. Then we have social, when we as a society return to a new normal, which was obviously a saying that we heard during COVID. Everybody talked about when can we go back to normal, and people said, well, there will be a new normal, whatever that might actually entail. And we can consider this when people resume somewhat normal activities and the pandemic is considered over. Obviously, these endings are all entangled in many ways and influence each other. The main point here is to note that epidemics end at different speeds for different people according to different criteria and spheres of society. And for some, the pandemic ended the moment masking mandates and social distancing efforts were lifted. In Norway, I remember very well being on the subway, hearing our version of Anthony Fauci say, the pandemic is over. The next day, masks were almost completely gone. And yet, when I traveled to San Francisco last year to visit friends, people were still very much wearing masks, even though the pandemic there also had been said that there's no more masking mandates. So obviously, masking, we can consider these things to be part of these epidemic endings. And obviously, from a biomedical perspective, one could ask the people who now suffer from what's called long COVID, whether or not COVID is over. We see this obviously has become highly contested in terms of is it a real phenomenon or not. The fact of the matter is that we still do see people, lots of people actually suffering from long COVID. For them, the pandemic is far from over. We can also actually see this in polio, a disease that we think we've eliminated, and we're on the verge, on the cusp of eliminating polio. And yet, every year globally, several thousand people get what's called post-polio syndrome. And for them, the pandemic or the epidemic of polio is far from over. So my point here is more to say, once again, that pandemics rarely end. They just transform, they linger on, and change. And that also brings us to the idea of pandemic preparedness. Why we failed, or I should say why we didn't manage as well as we could, and what does this say about healthcare and health? Because part of this idea of since pandemics or epidemics don't end, we obviously need to be prepared. That's just how life is. But how do we do it? So first of all, what does pandemic preparedness look like? Standard pandemic preparedness is usually nations and governments stocking up on what's called PPE, personal protective equipment, stocking up on antiretroviral drugs, stocking up or manufacturing vaccines, and having what's called epidemiological surveillance. All of this is quite technical, but all nations have them. So it's a very heavy health system focused. But my argument is that it's good, but not good enough. I think preparedness must mean a great deal more than these highly biomedical things. Obviously, these are important. But how we prepare for a pandemic says a lot about what we also consider pandemic success. Is pandemic handling only measured by how many people get sick or how many people die? Obviously, that's an important criteria. But across the globe, COVID obviously also had other unforeseen consequences, such as political division and also political unrest in different places. So I think we need to think broader about how we prepare. And it's interesting, and I'll show this on the next slide. This is, I'm not sure if you can see it, but I think this was very interesting. Part of the evaluation, which has been now conducted by what's called the Independent Panel on Pandemic Preparedness, the graph that you see here might just look like a lot of blobs, but on the vertical axis, we see death rates per 100,000 following the 51st days of the first recorded death. So the vertical axis is deaths per 100,000, but the horizontal axis, the one that lies, it describes the joint extended evaluation score of pandemic preparedness plans prior to COVID. This means that the further you're on this case, on the right-hand side, the better you scored prior to COVID, that your pandemic preparedness plans were scored really high, right? Like the US was scoring pretty high. The same with Japan when they were evaluated. And yet, if you also see that many of the countries that prior to COVID scored pretty high in terms of their pandemic preparedness also had quite high mortality rates. And that has raised a question for researchers. Why has this happened? There's different versions here. Obviously, this graph says a lot and also nothing, in a sense. Because one could say that this is also an artifact of aging demographics. Like most of the countries that scored well have an older demographics, while the countries that scored better have a younger demographic. That might be an artifact of that. But I think still, it raises some important questions of how we prepare as countries and as a global society. And I think, obviously, it also says something about high-income and low-income countries, the global north versus the global south. And I think this graph says something then of why and how we should prepare better next time around. And I think part of that is to think about preparedness as more holistic, rather than just thinking about stocking up on protective equipment and vaccines. I think we need to take into consideration what's called social vulnerability, meaning how people, their underlying health. I think we need strengthening trust in public institutions and science, and community engagement and cross-sectorial work. Part of the reason why these preparedness plans fared poorly might be attributed to the ways in which they did not offer a holistic approach to pandemics and epidemics. One thing is that the ways in which we, in many cases, failed was to take into account social vulnerability as a risk factor, such as living conditions, overcrowded housing, and providing community-tailored communication. Communicating during a pandemic is as important as having masks. Knowing how to communicate with the population is key, I would say. Another key aspect is that we need to focus on building what's called surplus health in the population. One could say that we need also to combat health inequalities so that we as nations, across both sides of the Atlantic, have a healthy population. So we need to talk less about excess deaths, which was a term that obviously came during the pandemic, and start focusing on building surplus health. And this brings us to another part, which was how healthcare during the pandemic played out, what it can teach us about social inequalities, and what a health crisis is. First of all, I think COVID-19 was a crisis multiple. It was a public health crisis, obviously, but it was also a crisis of trust, I think. Trusting each other, trusting government, trusting science. It was also a crisis of medical evidence. Somebody actually wrote a comment in The Lancet, one of the more prestigious journals, saying that COVID-19 was the death of what's called evidence-based medicine, because things were happening so quickly. Evidence was generated almost by the minute, and then suddenly it changed. Obviously, this presents a huge communication challenge. How do you communicate changing evidence almost weekly? So that also brings us to the fact that I think COVID-19 was a communication crisis. It obviously also became a financial and economic crisis. After COVID, or post-COVID, as some say, the economy has taken a downturn across both sides of the Atlantic. There's different reasons for that, obviously, but it was obviously an economic crisis. And it was obviously also a crisis of inequality, seeing how people from different socioeconomic backgrounds were affected. And I think there was a very striking similarity in the beginning of the pandemic between the US, UK, and Scandinavia, three healthcare systems and political and cultural settings that usually are quite different. And yet there was one thing that I, as a researcher, I spent a lot of time doing research on how issues of economy or socioeconomic status and ethnicity, as we like to say in Norway and Scandinavia, or race, as would be the hallmark here, overlaps with health inequality. And interestingly enough, we saw in the beginning that so-called racialized minorities or ethnic minorities, both in the US, UK, and Scandinavia, were disproportionately hit in the beginning of the epidemic, both in terms of risk of getting COVID, and then when they were affected by COVID, they had higher risk of severe COVID disease. But this obviously didn't explain the entire picture. It also has to do with what kind of jobs you had, what kind of socioeconomic status you had, and what kind of underlying health you had. And yet it was interesting that both overcrowded housing in the UK, US, and Scandinavia were pointed out as a driver of the epidemic. What the pandemic showed then in terms of health inequalities has been perhaps the most clear example of how pandemics and epidemics are not what in medical terms have been called great equalizers. The idea that epidemics and pandemics can hit us all. In theory, this is obviously true. Everybody can get sick, but pandemics do hit differently, and they hit people according to different communities differently. If the pandemic taught us anything about how we provide healthcare, it was that epidemics and pandemics shed light on precisely how social inequality and disparities play out. Communities with lower socioeconomic status were also hit harder, such as essential workers in more manual labor works or jobs were often hit harder. People would, in some cases, have to choose between going to work and risk COVID or stay at home and risk losing their jobs and income. And actually, weirdly enough, coming from Norway, which usually don't have that kind of problematic, we saw actually this take place. And it's some similar evidence of this here in the US, which is obviously heartbreaking as somebody working in public health, seeing people having to choose between going to work and risk COVID because they were in so-called high contact, high risk jobs, or staying home and losing their jobs, right? And it should also be noted, I think, that one of the things that also we saw was the lack of engagement with communities themselves. Once again, coming back to this idea that COVID-19 is a communication crisis, and it's also a crisis of trust. I think we need to build healthcare systems that aren't necessarily so top-down heavy, but are more geared towards bottom-up initiatives where we help people where they are and communicate with them where they are. This might, I think, once again, we can actually jump to this one. What the pandemic taught us about the link between trust and pandemic response and care, because this is where I think really the pandemic preparedness plans that we had beforehand failed. Very few of the pandemic preparedness plans that the US had, that Norway had, that Denmark had, talked about trust as an important factor. We talked a lot about, like I said, having masks, having enough respirators, having enough hospital beds, and these are obviously key things. But as I'm sure many of you also experienced, COVID-19 became a problem of trust. And as I write here on the slide, in order to give healthcare, the population must trust the care given. This is obvious in any setting. And as one that has worked on issues of HIV and AIDS, there was obviously in the 80s and 90s, there was a huge trust crisis between the communities hardest affected by HIV and the healthcare system. Here in New York City has done a tremendous job on this. It's actually, I would say, it's a city to be commended for its efforts when it came to HIV, AIDS, and building trust. But we also saw this under COVID. And I think pandemics and epidemics are inherently about trust. Building trust and maintaining trust in an environment that often demands quick action in a setting of high uncertainty. This obviously makes trust paramount, but also very difficult. The pandemic also taught us about the importance of trust in dealing with a pandemic. And some researchers have pointed out to the fact that some countries which did well along certain parameters also had a high level of trust between its population and towards their government. This is obviously very relevant here, as many of these countries that scored quite high on trust were Scandinavian countries. Norway, Sweden, and Denmark scored traditionally quite high when it comes to trust between its population and its government, and at least Norway and Denmark fared fairly well when it came to people dying of COVID. Sweden was an outlier, as many of you have heard. But retrospectively, we see now data that might tell a different story. So the jury is still out, but still, the idea of trust is important. I think the pandemic taught us about the value of trust and the importance of having trust in a population. And I think here, obviously, national context and political climate has a lot to do with it. How do we build trust, I think, is key. And I also would like to say that part of that trust lies in how do we build trust in medical science and pandemic response. I think COVID-19 was a crisis of trust in medical science, unfortunately, and I think people doing medical research, me included, failed at communicating with the public, with politicians oftentimes. I think it impacted response and care. The way that people communicated why masks should be worn was one obvious idea. For instance, in Norway, the idea of masking became quite contentious in the beginning, because in the beginning we had public health officials saying that masks didn't really work. And it was and this is actually a quote, it was an Asian phenomenon. It didn't belong in a Nordic setting. Later on, obviously, they turned on their heels and said, it does work, it is important. Once again, imagine what we could have prevented if there was both good, clear communication and trust. We could have actually probably prevented a lot of disease and probably also deaths. And I think, how do we build trust in medical science? Because obviously epidemics and pandemics are are fast-paced events. And I think part of that is openness, communicating uncertainty, and allow for disagreements publicly. I think in Norway, for instance, going back to where I did my research and I'm mostly invested, even though I'm heavily invested in the US as well after all these years, I think one of the things that became evident was that actually the conflict that was between the Norwegian Institute of Public Health, the Ministry of Health, and the government itself, there was this weird triangle that we have in Norway, was open debate, it was open conflict actually. It turned out to foster a climate of openness where actually the public said, okay, we see that even the experts disagree, but they at least communicate with us fairly openly and actually daily. They had daily press conferences. So I do believe that communicating uncertainty is part of pandemic response. Obviously, you have to do it clearly and in terms that aren't alienating or fail to capture the situation. So with that being said, that kind of also leads us to one of the things that was both the pandemic's greatest success, I would say, and obviously its greatest failure, and that was vaccines, I would say. And I'll tell you, I'll try to make that a bit clearer, but I think the vaccines were also an issue of trust and of communication, communicating how we should distribute vaccines and who should take vaccines, etc., and their effects. Because this is a map that visualizes what some has called vaccine nationalism. And the countries that are shaded darker are the ones that had the most vaccines at the time of this graph or dashboard. And that it's dated April 21st, 2021. And it's obviously quite clear that the US, Canada, the Scandinavian countries, and the UK had lots of vaccines at this time. Sub-Saharan Africa, on the other hand, had almost none. And I think this is also what we need to learn from the pandemic. We need to prevent this from happening next time around. Where is the... Sorry. Oh, sorry. I seem to have lost my mouse clicker here. Well, in any case, I think the vaccines provide a great example of two opposing and ambivalent issues. On the one hand, vaccine development has never happened as quickly as it did during COVID. We fast-tracked science to an extent that was, I mean, really the idea of Operation Hyperspeed or Hyperdrive, there was something like that, they called it here in the US, really worked. And it was a tremendous, actually, achievement of the global scientific community. Just a couple of weeks after COVID, we have mapped the entire genome of COVID-19. And that was due to a global endeavor, science working at its best. And they were quite effective also, right? The vaccines, at least the RNA vaccines, were highly effective. They worked. But on the other hand, I think one of the greatest failures of the vaccines were how they also we failed to distribute them equitably across the globe. I think it really showed how global inequalities across the global north and the global south still very much is in effect. So the greatest global achievement that we had also shed light once again on the failings of being showing solidarity towards countries which are low and middle income countries. And I think we had a slogan called "No one's safe until we're all safe." It was a great slogan, but it failed in reality when it came to vaccines in global terms. And I think vaccine nationalism shows the complexity of vaccine politics globally. Obviously, it's not as easy as saying, you know, we should just distribute vaccines. I don't think there's anybody in global health or in health in Scandinavia or in the US who thinks that it's, you know, a sort of magic bullet to say that everybody should have it. But I think there are things that should change. And I think one of the things, for instance, is the slogan from Médecins Sans Frontières, the Doctors Without Borders, who had a campaign saying that medicine shouldn't be a luxury. And I think during a pandemic, another thing that we need to learn when the next one comes is that we should have mechanisms in place for equitable distribution of vaccines, perhaps even patent suspension during a pandemic. I mean, obviously, pharmaceutical companies are stock traded, so they would need to earn money. But perhaps during a pandemic, there should be a suspension of patents or a price cap so that everybody can partake in it. And I think this was the greatest failure of the pandemic. So all of this is to say, and I'll shortly round off by my second to last slide, is will there be another pandemic? I can resoundly say yes, it will. But the trick now, both in the US and in Scandinavia and globally, is to prevent an outbreak of becoming a global pandemic. Outbreaks will always be there. They've always been there. But we need to limit them so that they don't become global threats to our health and security. And I think we can only do that by globally working together. And that's why I think, for instance, me being here at the American Scandinavian Foundation, it's a small part in collaborating globally across different disciplines and across different themes. I think another thing that says or bespeaks the fact that there will be another pandemic is also that more and more industry are now, or people actually I should say, are more and more now than ever before in contact with wilderness and habitats with wild animals. Logging industry, for instance, into untouched rainforests. And this isn't just about climate or preservation, but it's actually about ensuring that humans don't necessarily intrude into habitats where wildlife flourish and the contact zones between humans and wild animals furnishes us with opportunities for infection. And then I think my perhaps positive takeaway point would be that what we saw with the vaccines in the beginning, how they were developed, gives us hope that global collaboration and working together actually can work. And I think it can work politically. I still believe that we see that now. We see, for instance, with the war in Ukraine, how the global north or part of the West and NATO come together brings hope that we can actually do the same when the next pandemic comes. Because I do think it will come. But hopefully we'll be able to limit it to becoming a more local outbreak and not a global pandemic. But that means that we need to attend to global inequalities when it comes to health. We need to ensure that people are protected prior to a pandemic. It doesn't really help much if we act under a pandemic if we can't prepare correctly. So I will actually leave it at that. We had 45 minutes. But I would like to give a huge thank you to the American Scandinavian Foundation for the support. It's been wonderful being a recipient of the lectureship that brought me to Dallas. Thought that was a wonderful experience after 3 or some years at Berkeley. It was great seeing another part of America. I'd also like to thank, obviously, my people back home, the Center for Sustainable Healthcare Education at the Faculty of Medicine, where I do my daily work. and then Southern Methodist University and Department of Anthropology for their support while I was there. And with that, I thank you for your attention and for coming. We can open the floor if people have questions. Thank you.
People were shut down if they had other ideas or questions. Can you speak on that? What was your feeling about that?
I think you're very right. I was part of a group that worked on human rights during the pandemic, looking at different settings globally. And obviously the pandemic also ushered in, unfortunately, some really problematic tensions between the freedom of speech, the freedom of free assembly, the freedom of family life. And I think the problem there is that, the way that we communicate and allow for disagreement during a crisis becomes so contentious and so tension-filled that politicians and also healthcare workers obviously are at a loss for how to deal with it. But I think we need to actually approach these issues more now after, quote unquote, the pandemic is over, because I think the next time it rolls around, for instance, in Norway, one of the largest problems that in retrospect have been criticized was the closing of schools, right, for children. And we're not sure if it actually had that much of an effect of limiting infections. But we are very, very concerned about the mental health issues of children, the way that some children had to stay home with abusive parents, where the hours that they were in school were actually the spaces where they were free of abuse. So obviously, that's obviously also another crisis, I could say, that the pandemic was also, in many cases, actually a crisis of human rights and basic, for instance, freedom of assembly. So I don't have a very good answer to it, but I do think that there's a fine line between implementing necessary and important infectious disease mitigation efforts and totally leaving to the wayside human rights and implementing draconic mitigation tactics that no one is served with.
I was interested in your comments on trust and how in Norway, eventually people came to feel okay that there were three different parts of the government that might disagree, but they still trusted. Because I feel like here that didn't happen anywhere near as much, that you would hear people say, well, how can it be possible that this agency disagrees with this agency, or that Dr. Fauci changed his mind about something? How do you address that in a place that's not Norway?
I think that's a very good question. And I've been thinking about it a lot since I've been living in the States and really enjoy my connections with the US, because you are very right. The scenes here were quite different, and I wonder how it translates. And some researchers on trust say that it has to do with baseline trust and how political systems are set up. But I think I would say that actually, and this is not just because I'm Norwegian, but and how it played out in Norway, but I do think being open and upfront about internal disagreements is good for transparency, because then the population also sees that, okay, it's okay to disagree as long as we do it, civilly, and we do it based on rational arguments. Because we had three different wings of government, so to speak, actually live televised or not every day, but they did have huge disagreements, and we still actually said, well, okay, I buy actor A's argument, so I will follow that. Or, okay, I see that actor A is in disagreement with actor B. But I think it furnished a climate of openness and I think also, at the end of the day, you got the sense that all three wings of government wanted people to be healthy. That was kind of like the take-home message, which I think helped, because then you could choose a side in a sense, but still realize that they still want you to be healthy and safe. It's just different paths that they chose. Yeah.
Can you speak about your opinion of how Sweden handled the pandemic? As
a Norwegian, I would love to. I mean, Sweden was interesting as like during the pandemic, we were all, you know, I had the TV on and I had my laptop on with live feeds with data coming in. And it was weird being there, right? Because, you know, you saw Sweden choosing to take a completely different path than Norway and Denmark. And we were actually kind of dumbstruck about it. We were just like, what is happening? Why are they doing this? And then, you know, the critique against Tegnell came, the state epidemiologist, the head epidemiologist, and he was adamant that the way that they handled it would, in the long run, actually pan out to be pretty much the same. And I think during the pandemic, it was a bit hard to get my brain around it, and I think a lot of Norwegians and Danes were like, this can't possibly end well. But now, the last time I actually checked, it looks like total mortality for Sweden, Denmark, and Norway will end up being about the same, because our mortality rates were just pushed into 2022 rather than 2021 and 2020. There's still, the jury is still a bit out on the data, but it looks like Tegnell actually ends up saying like, okay, we had a lot of deaths in 2020, but you will get them later on, which seems to be the case. So, I mean, I think it was interesting in the sense that a lot of people think that Norway, Sweden, and Denmark are so similar, that culturally, politically, demographically, and then suddenly Sweden just veers off and does something completely out of the box. And I'm not going to say which position was right or wrong. Obviously, to the point that you had, Swedes had larger freedoms during the pandemic, right? They had less restrictions. So I think in terms of mental health issues for teenagers and young adults or young children, Sweden might actually end up having less harms, but we'll see. But I think it's a good point. And once again, how are we going to approach this next time? Will we do as Sweden? Yeah, I don't know. Thank you. Thank you.